Hi, this is Edward Wayne from City of Hope Medical Center. I'm an assistant professor and a medical oncologist taking care of a gynecological cancer patient at the City of Hope. Today, I'm to give a brief introduction to the gynecological cancers. Gynecological cancers refer to those cancers that arise from female reproductive organs, which include ovarian cancer, uterine cancer, and cervical cancer, and less common cancers of vagina and vulva. I'm to focus on the ovarian cancer, uterine cancer, the cervical cancer, the top 10 most common gynecological cancers. Let's talk about ovarian cancer first. It is estimated that there are about 22,000 new cases and 14,000 ovarian cancer-caused deaths in the United States in this year. 5-year survival is increasing every year, up to 50% now. The number of new cases and ovarian cancer-caused deaths are declining in the past several decades. Ovarian cancer can take place in any age, but most frequently diagnosed among women aged from 55 years old to 65, with a median age of 63 at diagnosis. Under the microscope, not all cancer cells look the same. It consists of many different cell types. They can be classified as a high-grade serous carcinoma, which constituted more than 70% of ovarian cancer. And the next in red, clear cell carcinoma, about 10 to 26%. Endometrial carcinoma in yellow, about 7 to 24%. Others are rare, including carcinosarcoma, low-grade serous carcinoma, mucinous carcinoma, and some others. Not only the cancer cells under the microscope look different, genetic change in cancer cells are also quite different from one patient to another. Most of ovarian cancers, especially high-grade serous ovarian cancers, have one or more p53 mutation. On top of it, many other gene mutations may take place. You may know well about the BRCA1, BRCA2 mutations, which can be inherited. Tumor cells can also acquire mutations themselves. Some patients may have more mutations, some patients may have less mutations. Occasionally, we can detect no mutation in some of the patients by the current available genetic test. Here are two examples of a genetic test report from two of my patients. The report on the left showed that this patient has 22 mutations. Some of the mutations can be targeted for treatment, while the other patient on the right has only 2 mutations. There's no target mutations that we can target for treatment for this patient. Another feature of ovarian cancer is that it's usually diagnosed at a late stage. Most of ovarian cancer patients have a distant metastasis at the time of diagnosis because ovarian cancer patient has no specific symptoms. There's no reliable screening method for early diagnosis. Unlike other cancers, such as breast cancer, most of the patients are diagnosed at early stages. Similarly, cervical cancer and uterine cancer are diagnosed at an early stage with a localized disease. Well, most of the ovarian cancers have spread in the pelvis or abdomen at the time of diagnosis. Risk factors for ovarian cancer are usually genetic, inherited, or acquired mutation by cancer cells. If you have a family history of ovarian cancer or breast cancer, or if you have a mutation of BRCA1 or BRCA2, your risk to have ovarian cancer is high. Other factors, such as hormone replacement therapy, obesity, can increase ovarian cancer risk, but not much. Symptoms of ovarian cancer is not specific, usually presented at a late stage. Patient may have abdominal fullness, bloating, distension, may experience pain at abdomen and pelvis and back. Also may have urinary symptoms such as urgency and frequency. Patient may also feel tired, unintentional weight loss, but this is not specific. Other symptoms may include constipation, menstruation change, vaginal bleeding, abnormal discharge. Diagnosis of ovarian cancer requires a history and physical examination. If there's any concern or suspicion for ovarian cancer, further workup with blood work and immune studies is warranted. To make a final diagnosis, will need a biopsy or collect cells from ascites or plurifusion for pathology review. Further staining the tumor tissue or cells with the special markers or molecular test may be performed to make a final diagnosis. Surgery plays an important role in ovarian cancer treatment. If the tumor mass is too large or too extensive, or it's difficult to resect, chemotherapy can be given before surgery to reduce tumor burden and then reevaluate for interval debulking. After surgery, adjuvant chemotherapy is usually given to reduce recurrence. We now have several options for maintenance after adjuvant chemotherapy. We use agent to target the blood vessel or DNA repair for maintenance for indicated patients. Ovarian cancers frequently express estrogen receptors. Hormone therapy block estrogen function sometimes works pretty well, especially for treatment of low-grade ovarian cancer. Immunotherapy has been hard for cancer treatment, but unfortunately, it does not work well for ovarian cancer treatment. Only a small portion of ovarian cancers with a specific genetic change may benefit from immunotherapy. We have many clinical trials at the City of Hope. Patients, especially those patients had been treated with multiple lines of chemotherapy, may benefit from clinical trials. We can also get information from the trials to formulate future treatment for ovarian cancer. Now let's switch to uterine cancer. There are approximately 65,000 new cases in the United States this year, about 3 times higher than ovarian cancer. About 12,600 uterine cancer deaths, slightly less than that of ovarian cancer. The 5-year survival is more than 80% all these years. New cases have been unfortunately increasing in the past several decades, slightly. Mortality remains the same in the past several years. The major histology of endometrial cancer is endometrial type, 75%, mixed histology, 10%, papillary serous, less than 10%. We also have patients with clear cell carcinoma, carcinosarcoma, mucinous carcinoma, and rarely we can see patients with a squamous cell carcinoma and undifferentiated carcinoma, less than 1%. Endometrial cancer is classified in 2 types, type 1 and type 2. Type 1 uterine cancer includes those slow-growing cancers, low-grade with better prognosis, but not respond to chemo well. Type 2 consists of high-grade, serous papillary, rapid-growing cancers. Prognosis is poor. Obesity is a big risk factor for uterine cancer. Risk for either type 1 or type 2 increases a lot with the BMI. Other factors including excessive exposure to estrogen, either to estrogen therapy or tamoxifen use for treatment of other diseases. Early menarche, late menopause, infertility, nulliparity all increase the risk. Diabetes also increases the risk of uterine cancer. Other genetic disorders, cancer syndromes such as Lynch syndrome, increase the risk significantly. Symptoms of uterine cancer usually are presented earlier. Postmenopausal bleeding raises the concern, requires further evaluation. Other symptoms including abnormal discharge, urinary symptoms, pelvic pain, or abdominal pain, fatigue, and weight loss are common but not specific. Treatment of uterine cancer requires multidisciplinary collaboration. For localized disease without distant metastasis, surgical debulking plays a fundamental role. Most of the times, adjuvant chemotherapy and radiation are required after surgery to reduce recurrence. For metastatic or recurrent uterine cancer treatment, we have a traditional therapy, hormone therapy, agent target blood vessels. A part of uterine cancer with a specific genetic change may respond to immunotherapy well. Targeted therapy for uterine cancer is being actively developed. Uterine cancer is preventable. It can be reduced by a large number. The American Institute for Cancer Research is estimated that 59% of uterine cancer can be prevented by simply keeping a healthy weight, being physically active, which means 3 in 5 uterine cancer patients could have been prevented. In other words, in the whole country, more than 35,000 uterine cancer cases can be prevented every year. Now let's move on to cervical cancer. New cases and the number of deaths each year are trending down due to effective vaccination and regular screening. Cervical cancer tends to affect younger women than uterine cancer and ovarian cancer, frequently diagnosed in the age group of 35 to 44 years old, with a median age of 50 at the diagnosis. Almost all cervical cancers are associated with a kind of a virus infection, HPV, human papillomavirus. There are 2 genes of HPV, E6 and E7, which are responsible for tumor development. E6 inactivates p53, while E7 inactivates RB. Both p53 and RB are important tumor suppressors. Without p53 and RB, tumor is easy to arise. HPV also causes cancers other than cervical cancer, such as oral cancer, head and neck cancer, anal cancer that affect both men and women. There are more than 100 different types of HPV. Not all of them can cause cancer. Only a few of them, notably type 16 and type 18, are responsible for about 70% of cervical cancers. You may contract HPV once, twice, or more in your life, but usually your body will get rid of it in 1 or 2 years. Occasionally, the DNA of the virus may integrate into human genome and induce cancer. Now, we have vaccines against HPV. Gardasil, developed by Merck, is now on the market, which covers 9 different HPV subtypes. It is recommended for both men and women from 9 to 45 years old. It can protect infection from those viruses and reduce the risk of cervical cancer, vulval cancer, and vaginal cancer that affect women. It also reduces the risk of anal cancer, oral cancer, head and neck cancer that affect both men and women. It can also prevent HPV-induced precancer lesions and benign skin lesions such as genital warts induced by some type of HPV. Another practice helps reducing cervical cancer greatly is pap smear for cervical cancer screening. The U.S. Preventive Service Task Force and many other professional organizations provide similar recommendations for cervical cancer screening. As listed here, for ladies from 21 to 29 years old, pap smear with cytology every 3 years is recommended. For ladies from 30 to 65 years old, there are 3 options. You can do pap smear and cytology every 3 years, or HPV test every 5 years, or in combination every 5 years. For those more than 65 years old, if a prior test up to date and negative, screening can be discontinued. Treatment of localized cervical cancer include surgery for early stage, concurrent chemoradiation for locally advanced stage, followed by internal radiation, also called brachytherapy, with the goal of cure. For cervical cancer with distant metastasis or recurrent cervical cancers, treatment is challenging, options are limited, prognosis is poor. Let's talk about the side effect of chemotherapy. The most common side effects of chemotherapy are listed here. Almost always, more or less, patient will experience fatigue, poor appetite, and other GI symptoms, nausea and vomiting, constipation or diarrhea. Many chemo can induce hair loss, a painful side effect to ladies. Chemo can also cause weight loss, mood change, skin rashes. It may suppress bone marrow to make blood cells low. It may be toxic to kidney, liver, heart, or other organs and cause trouble. Many patients are scared of side effects and sometimes they refuse chemotherapy, but cancer is a deadly disease. We have to treat it. Otherwise, it will cause trouble much worse than the side effect of chemo. FDA-approved treatment have been intensively evaluated for benefit and risk. The benefits are almost always more than the risk that the patient can tolerate. We give medications before or after chemo to prevent, reduce, or treat side effects. Patients frequently ask what they should do, what kind of meals they should take when they are fighting cancers. It is important to keep a positive attitude, an active lifestyle, take small frequent meals as they can tolerate, usually no restrictions for that. Patients also ask if they should take supplement. I usually do not recommend a supplement while the patient is having chemotherapy because there's no clear evidence that the supplement can help, especially multivitamins and herbs, unless they are deficient for some kind of vitamins that need treatment. Thank you for your attention. You can reach me if you have any questions. You can find my contact information on the website of City of Hope.